my real pleasure to introduce Laura Ramsey to you. She joined my own institution, Children's Mercy Research Institute in Kansas City last August, and she is tasked to implement and develop in-house PGx testing at Children's Mercy. It has been a little bit of a bumpy road, and I think it's really nice to hear what the battles are, but also what the successes are, and where we go from where we are. So all yours, Laura.
Thank you, Andrea, for that wonderful introduction, and thanks to the organizers, Kelly and Marilyn and Terry for organizing this fantastic conference, and for all of you for sticking with us till the end. So thank you. For those of you who don't know about Children's Mercy, it's in Kansas City. It's a nonprofit children's hospital, independent children's hospital with about 8,000 employees, and it has 390 beds. This beautiful building here is the research building, the glass one. That's where the Genome Center is on the third floor, as well as the Clinical Pharmacology Group, also on the third floor of that nice new building. And for those of you that don't know, there is a Kansas City, Missouri, and a Kansas City, Kansas. And so we have hospitals in both places, but the main campus is on the Missouri side at the Adele Hall location that you can see on the map there between those two states. That many of you might also know that Children's Mercy has been a leader in clinical genomics for many years. They are using the hi-fi long-read sequencing clinically for diagnosis with PacBio Revios, and the cancer patients all get the short-read exome sequencing of the germline and the tumor, with long-read sequencing currently in validation process. We also have a research study that sequences patients and their families, and they've made enrolled over 6,000 patients and made over 1,700 diagnoses from that research study. You also might know that Children's Mercy has been a leader in pharmacogenetics for many years, being the home of Andrea Gadig and PharmVar. Steve Leader is there also. He's been on several CPIC guidelines, as have I. We've got a clinic model that I'll tell you about in a little bit, as well as a pediatric clinical pharmacology fellowship training program. So this is one of the ones that maybe Chris left off her fellowship training. This is a pharmacology fellowship training that is funded by the T32 from the NIH, from NICHD. We've trained 18 fellows since the grant started, and 24 total since the program started in 1999. And they can be MDs, they can be PharmDs, they can be, there's one APRN who also had a PhD, and incoming we have 2 people that have PhDs only. So I'm the co-director of this program now, and it is accredited by the American Board of Clinical Pharmacology, and so you can also sit for board certification through that organization. So the Goldilocks Clinic stands for the Genomic and Ontogeny Linked Dose Individualization and Clinical Optimization for Kids Clinic. You can see why we call it the Goldilocks Clinic. We have a pediatrician and a pharmacist. Tracy, our pharmacist, is here in the audience today. And they have telehealth visits with patients and families, and I'll go through the kind of service model in just a minute. But there's also a nurse and a social worker involved, as well as Andrea and I get involved in discussing the cases as well. So the nurse is the one that's getting the history, the medication history, and understanding what those adverse events have been in the past. The social worker is making sure, since many of our patients are coming through developmental and behavioral health, the social worker is really making sure that they are plugged in with the area's supports for all of the things that might be helpful to them. For many years, this has been going on for about 10 years, and they have always used an external testing lab. So right now, the clinician a clinician at the institution or even outside the institution can refer a patient to the Goldilocks clinic. And if the provider knows they want the pharmacogenetic test, then they can order it through our system. And then the lab does a pre-authorization here. With the insurance, a kit gets sent to the patient's house. And then Tracy and Alexa, the pharmacist and pediatrician, they see the patients to do the review of results and enter a note in the patient's chart. If the family is not sure if they want testing or not, they can go down this other side of things where the nurse calls the patient to make the appointment, take the history, and really get an understanding of why they might be interested in pharmacogenetic testing. And then they have a first telehealth appointment to see whether testing will be helpful or not based on the medications that they're on. And then the Goldilocks physician, Alexa, can order the test herself, and the lab does the insurance pre-auth again, and then the kit gets sent to the patient house, and they go down this route. So when I got to Children's Mercy a little less than a year ago, I could see the Genome Center down the hall from my office in the clinical pharmacology group, but they weren't really connected or talking much. But we have the expertise to do the testing in-house and the pharmacogenetics expertise to know what to do with the information. We have clinicians that have bought into it already and been using this service for a decade already. Our informatics team, I had to talk to them and see if they would create alerts and clinical decision support. And so really that's how Steve Leader got me to come to Children's Mercy, was the opportunity to build an in-house pharmacogenetic testing program with the clinical decision support that would be helpful. And it didn't hurt that along the way, the commercial lab that we were using stopped accepting samples from us. So that's kind of the top bar, the current state where we're at right now. And where we would like to get to is, having a test and with clinical decision support. Right now, it's just a note that goes into the chart, which is not very helpful or easy to find after the testing is done. And so this is how I kind of imagined it. 2 separate tracks, really, with developing the lab test, working with the clinical lab to get the test validated, and how we were going to report it. And then working with the IS team to develop the alerts, design the rules, and test the clinical decision support rules. And bringing together all of these stakeholders in the middle that were touching different parts of this, and adding on education for the providers and the people ordering the test and the people talking to the insurance companies for pre-auths, and all of those people need some education about what this test is for. And that's what I had imagined, but turns out we did that second part, the test validation, twice, because the molecular oncology group was really excited about using all that sequencing data that they're already generating. They didn't see why we were sending out TPMT testing when we have the DNA already sequenced in our lab. So they really wanted to take advantage of that sequencing, use that clinically. So I'll talk a little bit about how they validated the test and did the result reporting. They were the first ones to get the results into the medical record. But that did grow the stakeholder piece a bit and make things a little bit potentially confusing for the users. But we'll have to do some education really on how to order the test and whatnot. So the oncology pharmacogenetics, the TPMT testing had been performed for leukemia patients as a send-out test, and occasionally they might order a NUD-T15 if they think a patient might have a problem, if they're a TPMT normal metabolizer and kind of wonder why there's some myelosuppression. And so the molecular oncology group, they, as soon as I got there, really asked to collaborate and get this implemented. They are using 300x short read whole exome sequencing right now, and using the Illumina Dragon star allele caller. And we had some GetRM Coriell cell lines that covered 7 NUD-T15 alleles and 6 TPMT alleles, and they found it to be 100% concordant when they did the validation. So that meant we could move ahead, and then they got this into the Cerner medical record, where you can see here there's a lab results section where it says cancer pharmacogenomics, and underneath there's a report as well as the genotype and the TPMT phenotype here, and below that the NUD-T15 genotype and phenotype. And we're working on getting some alerts written. These are not going to be this long, I promise you. Don't worry, James. But we are working definitely on getting the alert language and working with the providers on what they want to see when they might encounter this alert, what would be helpful to them, and when in the ordering process it will be helpful. So I'm going to go through some of the challenges, each with the oncology test as well as the panel-based test. Since we're using the Illumina Dragon pipeline, it does not call rare variants. We have the research sequencing side of things, where we found 2 exonic TPMT variants among 113 patients with whole exome sequencing. So we know that it's missing some rare variants. And obviously phasing with short reads is not possible, as Vicki mentioned earlier. So our report, when these 2 variants are tested and found to be heterozygous, this 6 base pair insertion and this variant here, when both of those are present, we can't tell if it's a star 1, star 2 intermediate metabolizer or a star 3, star 6 poor metabolizer. So at that point, our report says genotyping the patient's biological parents could aid in assessing the true metabolizer status. So that is something we offer. And we have this education for the clinicians on an external-facing website, and that's what this QR code takes you to if you'd like to see that. Some of the pharmacogenes are not covered very well by whole exome sequencing. The capture for this assay was not developed for pharmacogenetics, but with the upcoming switch to long read sequencing, we will be able to capture all of those pharmacogenes. Our clinical decision support has been a little bumpy as well. It's the first gene drug pair that we've tried to implement, so there's a lot of learning, and there's plenty of people who have gone down this road before, and so many of you I have talked to asking for your help, and I think it's been very helpful. But we're still working on how things in our Cerner system work and our workflows to make sure that we are building this in a way that's not disrupting the clinical workflow. Right now, it's ordered as an add-on test. So you order the sequencing test, and then you can order an add-on test for TPMT and NUD-T15. The genetics lab also intercepts the orders for the send-out test for TPMT and encourages them to replace it with this add-on test for both genes. Right now, all of our sequencing tests are standing at a turnaround time of about 45 days, so that's not ideal. And a third PacBio Revio is on its way to Kansas City. All right, now I'll switch gears a little bit to the panel test. We had a QuantStudio instrument that was not being used in the clinical lab. Andrea has 2 down the hall in her research lab also, but this one was in the clinical lab. And so we helped design a TACMan assay that kind of built off their existing PGX Express content. So we added, some of my favorite variants in SLC01B1 and some of Andrea's favorite variants in CYP2D6 and TPMT and NUD-T15, of course, and removed some of the ones that we didn't want to report on, like everybody's least favorite gene, MTHFR. But we wanted to be sure that it covered the AMP Tier 1 and Tier 2 alleles, be a comparable cost to the send-out testing that we were doing, and have a decent turnaround time. And so we think it might be around 10 days or less. The validation process is underway as we speak, so we'll see. It's not live yet, but as we have been going through this process, we've encountered a few challenges as well, like there being no TACMAN assays for some variants of interest. CYP3A4 star 20 is one that we wanted to include, but we're not able to. And obviously, we can't phase these either, so it has the similar issue. And you can't see what you don't test for, so there are likely rare variants that we're not getting with this panel either. And being an instrument that had never been used by the clinical lab before, they have struggled a little bit with the software and the implementation, the testing in using the instrument. So that's taken some significant time as well. So the future, as Vicki mentioned, is whole genome sequencing long reads. And there are several advantages and disadvantages to this as well. Like we will be able to phase the haplotypes. We won't have to say NUD-T15 star 1, star 2, or star 3, star 6 anymore. We will be able to call the alleles with the variants in non-coding regions, like CYP3A5 and CYP2C19. We will be able to really understand the CYP2D6 hybrid alleles. We know that other people have done this, so we can thankfully ride their coattails and not reinvent the wheel, and we will be able to discover novel alleles. But one of the disadvantages is then we have to know what to do with those novel alleles, how to report them, and understand what they mean, and have a research pipeline for understanding their function. So an analysis pipeline also has to be developed, and there will be a longer turnaround time for the results than the panel test. So with that, I will stop and say thank you to all of my new friends at Children's Mercy who have been involved in this. And you can see it's quite a lot of people that have come together to help make this happen. So thank you.
Well, thank you so much, Laura, for sharing our successes, but also really sharing that it's never easy and there are always unforeseen challenges coming up when you try to do this in your institution. So we have time for a couple of questions. Okay.
Just a question, is that PacBio you're using for long read?
Yes, the Revio. Mm-hmm.
And targeted? You're determining the targets or whole genome?
Whole genome.
That is whole genome, what the Genome Center is doing, because these data are created often from the Genomics for Kids program with the aim to really find what the rare diseases are in these kids. And so this is the setup. And so we, of course, try to really capitalize on all the data and the workflow they have set up.
Mm-hmm.
So.
Yes. Yeah, but right now, all of the sequencing, they're not reporting pharmacogene results for anybody other than those kids with oncology where the add-on test for TPMT and NUD-T15 is available.
Do you think there were any challenges, particularly being in a pediatric hospital versus an adult hospital?
Well, the PGX Express array didn't have the TPMT and NUD-T15 on there. That is the most commonly implemented gene-drug pairs in pediatrics. So that was something that, of course, we had to have. Otherwise, I think we can learn from a lot of people and what they have done, even at the adult institutions. Burns.
Laura, congratulations on your position and on this is, setting up your own test is not for the faint of heart, to say the least.
Only my part-time job, too. Still have to run a research lab.
Yeah, so I'm sure you'll be successful as you have been in the past. So question then, with a turnaround time of 45 days, um, and this is, I'm just seeking advice for others who are going down this road. Does it make sense to set up an interim solution for testing, or are you just going to wait for things to roll out?
That's for the sequencing side of things. And, the panel test should be the faster result, like for a psychiatry kid or a GI kid that is not needing the whole exome or whole genome sequencing.
Okay.
So there's also a way to say, I need to start the thiopurines next week. Get me that result stat, so then they can push it through and move it to the top of the queue if it's high priority and get that result faster. But when it's just like, oh, everybody's ordering it, you go to the bottom of the list and it can take 45 days. But they did just get another PacBio, so the the time should be shorter to get the sequencing data, and they are hiring another clinical lab director to enable the sign out of those tests to reduce that turnaround time for sequencing.
Well, thank you so much. I would like to introduce, although she doesn't need an introduction, Marilyn Ritchie.